Great. Welcome everybody to the third of our Canadian Health Workforce Network webinars. I'm very pleased to be hosting. My name is Ivy Bourgeot and I'm one of the leads at the network. And I'm very pleased to be able to have our team led by Mary presenting today. Before I pass over to Mary, I would like to do our land acknowledgement and just acknowledge where we are situated here. We are gathered across Canada on territories of First Nations, Inuit, and Métis peoples. Here in what is known as Ottawa, where I'm situated, we are located on the unceded territory of the Algonquin Anishinaabe Nation. We extend our respect to all First Nations, Inuit, and Métis peoples for their valuable past and present contributions to this land. And we recognize that land acknowledgements are only one small part of disrupting Indigenous erasure and dismantling colonial structures. And we encourage everybody to recognize where they are. If you haven't spent time knowing a treaty, find out about the treaty in your particular area. And so with that, I would like to pass over to Mary to present.
Thanks very much, Ivy. Have we got the slides up? Kate? Super. So if you could just move to slide 2. Thank you. So I'm just going to provide a bit of an overview to kick us off of tell you a little bit about the project, the team goals, phases, and timelines, and then Yelena and Danielle will walk us through the preliminary findings from the literature reviews. And then we're very pleased to have Glenn Birmicum from the Canadian Psychological Association and Rebecca Jesseman from the Canadian Centre on Substance Use and Addiction to kick off the discussion with some feedback and reflections. Next slide, please, Kate. So Ivy and I made the case for this project in Hill Times op-ed earlier this month. You know, that if we want to respond to expected increases in the mental health and substance use needs of the population in Canada, we really need to focus on the workforce that provides services and supports of that nature, that their needs and capacity is really key. And that's really the motivation for this project is both to better equip us to respond to emerging needs, but also to address some long-standing gaps in our knowledge of the capacity and needs of the mental health and substance use workforce. Next slide, please. So we were very pleased to be successful in obtaining an operating grant from the Canadian Institutes for Health Research for a 12-month, $200,000 study to assess the capacity of the full mental health and substance use workforce across the country to better match those emerging needs and prepare for longer-term shifts in service delivery. And one of the exciting things about this project is the very strong focus on both mental health and substance use together in a combined project, recognizing the interrelationship between mental health and substance use needs, but also how that interrelationship is also threaded through the workforce. And in addition, another exciting component of the project is the inclusion and consideration of both the publicly funded and the privately funded sides of the workforce. Mental health and substance use, much more than for physical health care, is very much divided between the public and privately financed systems, especially our employer funded services. And you know, the big quote here from our op-ed was that you know, even with some of the significant investments that we've seen, mental health and substance use services don't just magically appear without planning. without intentional collection of information and applying that information into intelligent planning. Next slide, please. So the project team, many of whom are here today, well, probably all of whom are here today, but some of us are presenting, is a great mix of researchers at different points in their careers, as well as representation from several institutions, Carleton, University of Ottawa, Athabasca University, and McGill. And I may have forgotten one institution, but I think I've covered them all. Next slide, please. So also very pleased to be building a really exciting advisory committee with representatives from the mental health sector, the substance use sector, many different provider associations and colleges, the privately financed sector, as well as everything from psychiatrists to peer support workers. Really important to have all of these perspectives represented, as well as Health Canada and the Canadian Institute for Health Information. Next slide, please. So, you know, I've already mentioned this. These are the two goals: to better understand and address the effects of the pandemic on the capacity of this workforce, and to better, to develop evidence to actually better match access to mental health services with the people who need them most. So the workforce, and then how the workforce contributes to the mental health and well-being of the population. Next slide, please. This is the timeline tracking from September through to September next year. We're just at the end of phase 1A here on the far left. We may do a few key informant interviews to help inform the development of the next phase, which is a survey, which we aim to have out in the field in January or February. In March, we will supplement the survey with more in-depth key informant interviews and be working towards a virtual policy dialogue in late spring. Next slide. Oh, and this is where I will turn it over to my colleague Yelena to kick off the review of the preliminary findings.
Okay, hello everyone. So I'll tell you now about these preliminary findings. Our rapid literature synthesis includes both academic and gray literature that helps answer our research questions. Search strategy for academic literature has been constructed in collaboration with Alan L. Hoffey, librarian from U of Ottawa. And the searches have been performed in CINAHL, Medline, and Google Scholar using 4 main concepts that are outlined on the left side of the screen here. Out of 270 results in the CINAHL database, less than 1/5 were selected for review during the initial process of screening. Searches in Medline and Google Scholar are still in progress. Gray literature search has involved search of international, national, and provincial organizations using the same 4 key concepts that we used for academic search. For instance, the gray literature search includes searching provincial regulatory bodies, national associations, advocacy groups, service providers, etc. As it is outlined on this slide, we would appreciate if you could let us know if you are aware of any sources that should be included in our literature review. So next slide, please. So our preliminary research of the literature reveals that most of the papers reports and other documents are related to 4 main categories, buckets that are outlined on the screen here. These are population level MHSU needs, mental health of healthcare workforce, mental health of MHSU workforce, and MHSU workforce capacity. Next slide, please. The preliminary findings of our literature review could be sorted according to the following 4 themes: emerging MHSU population service needs in response to pandemics, disasters, impact of pandemics, disasters on MHSU workforce capacity or service provision, MHSU workforce responses, and impact of gender and other social identities. Next slide, please. So the next set of slides is dedicated to overview of each of the themes. So some literature documents rise in MHSU needs of population response to COVID-19 and other pandemics or disasters. For instance, a study by Holling and colleagues assesses the frequency of psychological distress during the beginning of the COVID-19 pandemic in people with no history of mental health issues. It finds that 15% of the sample experienced 2 psychological distress symptoms for at least 3 days over the past week, and 13% had 3 or more symptoms. Next slide, please. Some literature reports on negative impacts that COVID-19 or other pandemics or disasters have had on MHSU workforce capacity or service provision. For example, in her paper, Knopf notes that according to some US data, 65% of substance abuse disorder treatment programs report that the pandemic has reduced capacity, with 21% reporting it has reduced capacity by more than half. And she adds that 58 of programs have lost staff, with 7% unable to provide all necessary services. Next slide. Some literature indicates some literature shows these talks about these different strategies that would be employed in order to better respond to needs of population during crisis. And some of the strategies discussed are rapid implementation of telepsychiatry, telemedicine, virtual visits, consultations, shifting from specialized to less specialized services, etc. In their article, Sharma and colleagues described the implementation of home-based telemental health in a large child psychiatry department during the COVID-19 crisis. And this implementation was achieved in 6 months, despite some challenges that they encountered in the process. Okay. Some papers emphasize the importance of taking into consideration gender, race, ethnicity, and other social identities in MHSU population needs, MHSU service provision, and MHSU workforce capacity responses during COVID-19 crisis. It has been noted that COVID-19 has exacerbated the already problematic gaps in culturally and linguistically appropriate care. And as response, in the light of these considerations, some authors advocate for culturally and racially sensitive interventions. For instance, in their paper, Novacek and colleagues call for race-conscious and culturally competent interventions that consider factors such as discrimination, distrust of healthcare providers, and historical and racial trauma. So now I will pass it over to Danielle, who will tell you more about Gray literature findings. Thank you.
Thank you, Jelena. And as Jelena nicely outlined with the methods, the Grey Literature search has really followed quite similarly to the formal literature search. And just as a note, these are preliminary findings, but nonetheless, we've found some interesting results even so far. So going on to the same themes that Jelena presented, we found some emerging mental health and substance use population service needs. And this has come out really strongly with a higher frequency of Grey Literature sources, noting the expectation of and already worsening mental health issues that are happening at a population level. So there's certainly been a number of documents that are trying to note the need to prepare for the increased need. And we'll discuss in a bit about what type of preparation has been happening. You'll see here there was a nice statement from the Volunteer Yukon Association, where they're noting that we want to try and plan for the impact on the pandemic for both the staff members and people of the community. So I think that's an important Canadian finding, whereas there's also been some international findings here. With this second example on your right-hand side, you'll see the government of India's Ministry of Health has been trying to already put some guidelines in place to prepare for this emergence of MHSU service needs. So if you don't mind going to the next slide. Thank you. And of course, with an increased need, this impacts the mental health and substance use capacity. There has been much less that we've found so far in the Grey Literature about this capacity. There's certainly been peripheral documents saying that there may be a need for increased capacity and increasing the workforce, but less of how this will happen. In the international literature, the World Health Organization has definitely highlighted this and the service disruptions that have occurred. And if you look on the right-hand side, we have the examples here. Sorry, that just notes that, for example, yeah, that's the sorry, if you go, yes, that's the correct slide. That there have been some service providers that are trying to get licensed in other places because there could be interruptions in the services that are provided. So if you can go to slide 18, please, perfect. So here we have some of the responses that have occurred. And in the Grey Literature, there have definitely been some themes that have come up for workforce responses, both for mental health and substance use, but also for careers such as nursing or a physician, where it's not necessarily only mental health and substance use care being provided, but the changes in the response that have been made may impact those patients as well. So for example, Health Canada has issued some temporary exemptions for the prescriptions of controlled substances for pharmacists. So while this may be, maybe pharmacists have made other changes in their care, this is relevant for the substance use, for individuals using substances as well. So that's definitely been a finding that's come out both in Canada and at an international level too. So if we could go to the next slide, please. And there have been some interesting findings about considering equity, especially in Canada here. There have been some notes in the Grey Literature documents highlighting that having gender-specific and culturally appropriate services for mental health and substance use needs will be quite important. So the government of Northwest Territories had noted that they're trying to plan for some gender-specific programming to be prepared once these needs come through. There have also been some calls for culturally respectful community-based programs to start to be implemented to also prepare for what is going to happen. So this is similar with international literature, where there's been a focus on, in this example here, Indigenous populations who may be particularly vulnerable in the context of a pandemic, and trying to determine how we can also prepare to address those unique needs. And next slide, please. Thank you. So I'll stop there, and I guess I'll turn it back to Jelena for this.
Okay, so this is just a snapshot of literature extraction tools that we are using to extract the literature according to the relevant categories. And they're like, we are using two literature extraction tools, one for gray literature, one for academic, and the academic literature extraction tool is a little bit more detailed and has more categories than a gray one, but we are trying to capture the main themes, and we are in the process of extraction now. Thank you.
Next slide, please. All right, so just to wrap things up, some key emerging findings. The literature confirming the emerging increase in the needs with regard to mental health and substance use across the population, or at least the potential for this. Secondly, that disruptions are exacerbating pre-existing challenges in the capacity of the mental health and substance use workforce, that responses and changes in the mental health and substance use workforce include, of course, the pivot to virtual service provision, but also feature some redeployments, some task shifting in terms of drawing on providers with different levels of qualifications, and also the development of some guidelines. And then this last finding around how the pandemic is really exacerbating inequities with regard to mental health and substance use. And we see this not just in Canada, but also in the international literature from the Global South. So we're very pleased to have, as I mentioned, Rebecca Jesseman and Glenn Brimacombe here to kick off the discussion. We very much encourage you to provide any suggestions or feedback in the chat, and Ivy will also moderate a Q&A after Rebecca and Glenn have shared some reflections. So I'll start with Rebecca Jesseman, who is the Director of Policy with the Canadian Centre on Substance Use and Addiction. If you could start us off, Rebecca, that would be great.
Absolutely, and even reminded to unmute myself. So thank you for an excellent summary and for including CCSA in this work. So in response to the framing questions, in terms of what's been captured well, certainly summarizing what we know about COVID exacerbating existing challenges and inequities in access to care for substance use services. And I love that opening slide with the sort of quasi-Venn diagram, where there's a little tiny sliver that refers to the attention being paid to the needs of the mental health and substance use workforce. I think that's so illustrative of the challenges that the field is facing. Certainly capturing the rapid expansion of virtual care is important, and also speaking to what we can expect in terms of increased population needs. In terms of some of the gaps, I think we need to keep diving deeper into and some of this just isn't available. I mean, the impacts of a long-term pandemic on mental health and substance use versus the existing literature, which is focused on time-limited crises, for example. Also a bit more on substance use specific impacts with a focus on equity. So a lot of the literature seems to refer primarily to mental health. Impacts specific to the Canadian context, and the attention to private providers is certainly a gap in evidence that I'm really looking forward to seeing what comes from the work that the team has proposed in this area. In terms of some of the priorities moving forward, I'll speak to three. So I would say tracking the emerging needs, understanding the workforce needs, and providing support for the workforce. So in terms of tracking the emerging population needs, we're seeing from early survey data, approximately 20% of the population reporting increased alcohol consumption. And we're seeing that use is associated with people who are staying at home more, with younger adults, with folks with childcare responsibilities. There's an intersection with poor reported mental health and with poor and multicultural communities. We're also hearing from our stakeholders about the loss of access to social supports, including which increases the risk for either return to use or higher risk use. And we're also, of course, seeing intersection with the opioid crisis. In terms of what this tells us around the health workforce is where and how to focus the limited workforce resources that we have, and how to focus capacity building. So some of that is around some of the earlier intervention, looking at capacity for integrated services for both mental health and substance use to address that intersection. And certainly the need to reflect population diversity and offer programs that are culturally appropriate. And again, this is a gap area that certainly pre-exists COVID and that COVID has shone a light on and exacerbated. Also in terms of earlier outreach, so looking toward public messaging and education, supporting early intervention. And that involves working with the mental health and substance use workforce, but also the broader primary care and health professional workforce that people might be more likely to come in contact with rather than the specialized service providers. It also means we need to facilitate access to peer supports and recovery supports in terms of reducing the risk of re-entering harmful substance use. And we know that that is an area of the workforce that is often neglected. And finally, equipping the workforce to work with marginalized populations. And that often includes the need to address stigma. So COVID, as we know, has specific risks around people who are unstably housed, for example, people who are in institutional settings. And there's often very complex needs associated with those population groups, and a lot of challenges with working with them that requires resources, requires education, and requires anti-stigma initiatives. In terms of understanding workforce needs, we heard, similar to what was noted in the California study, that community providers were being forced to shut down if they were not deemed essential services, although it's notable that alcohol retailers were essential services, and that many of them continue to operate with reduced capacity. There are ongoing challenges with increased resources needed to acquire PPE, to conduct training in PPE use, and to make some of the structural and operational changes to programs and spaces to accommodate physical distancing. We certainly hear about the need for training tools for providing virtual care. This is a very new way of interacting with clients for many service providers, and clients aren't the only ones who are experiencing challenges associated to that change. And finally, we're hearing concerns about substance use workers being redeployed to support COVID responses. And it's going to be interesting to look at the impact that has on the individuals who are being taken away from their sort of home base, and also the impact on capacity at the system level. So in terms of providing support, we really haven't traditionally provided sufficient training supports or professional recognition to the substance use workforce, and that includes peer supports as well. But we look to that workforce to help us when we're most in need, including now in the context of COVID. And we really need to continue to pay attention to the need for support that's made more acute by the intersection of COVID and the overdose crisis, particularly for those who are working as peers and for those who are working in harm reduction and experiencing significant levels of burnout, grief, and trauma. So I'll close just in terms of some challenges and opportunities. Some of the challenges, filling information gaps is fundamental, and data collection in the substance use field is notoriously poor, unfortunately. When we look at a lot of the work underway is very promising, but we still lack very basic data about community-based services that would help us to understand the changes in service delivery and workforce capacity. There's also a lack of regulation in the substance use field. Which means that we need to be creative about some of the levers that we use to drive practice and policy changes. And all of this, of course, requires resources and funding to support capacity building in the health human resources focused on mental health and substance use. In terms of some opportunities, I want to leave it on a high note. We're highlighting these gaps at a time that attention to health human resources is high, and resource attention is included in that. So there is potential. There's also great potential to leverage complementary initiatives in the field, including workforce competencies that my organization CHWN is updating, clinical guidance documents that organizations such as BCCSU are developing, program operating standards such as those being developed by HSO, and needs-based planning such as the initiative being led by the Center for Addiction and Mental Health. There's also opportunities to leverage attention to the need for broader standards for supportive care and better and more timely health system data collection. We traditionally have not looked at residential community treatment system as part of the supportive care network, but I think this is a unique opportunity to do so and to identify the fact that many of the challenges experienced in the broader supportive care field are also experienced in the substance use residential treatment system. And finally, supporting innovation that is being driven by providers and taking advantage of that appetite for an environment supportive of change. So examples include the safe supply models and expanded access to pharmaceuticals and takeaway opioid agonist treatments. And also looking at the potential for virtual care to expand our access. We're hearing stories from health service providers who are now able to see clients more regularly through virtual services rather than waiting to do the circuit if they're serving rural or remote communities. So I will end there, say thank you very much to Ivy, Mary, and the team, and look forward to the discussion.
Thank you very much, Rebecca. I've neglected to mention my role with the Mental Health Commission of Canada as the director of our COVID policy response initiative, and have had the pleasure of working closely with Rebecca in that capacity. I hope that her comments have given participants of the webinar some appreciation for the complexities of what we're setting out to do, but also just how exciting and awesome it is to be having this conversation and bringing these components that often are either overlooked or not talked about together into one conversation. So really looking forward to continuing on. I'll turn it now to Glenn Brimacombe, who I'm very pleased is here on behalf of the Canadian Psychologist Association, sorry, Glenn. He's the Director of Policy and Public Affairs, and really looking forward to hearing his reflections.
So good afternoon, everyone. It's a pleasure to be here. And I'm here really on behalf of Dr. Karen Cohen, who is the CEO of the Canadian Psychological Association. I'm a poor imitation for her, but nonetheless, I'll share some of my thoughts in terms of looking at the slides and participating as a member of the advisory committee. I don't think anyone would argue that this is clearly an important area. It's unprecedented in many respects. It is a timely study that is needed. And in the context in which we face right now and find ourselves, when you look at the survey information that is being put out into the public milieu, you see that generally speaking, the trends are that the mental health of Canadians is in decline. And then when you match that up against some of the pandemic waves theory and work, so I think of Dr. Victor Sengs and his 4 pandemic waves, the question in my mind, which turns to the whole issue of system capacity and the ability of the workforce to deal with the growing demand for access to mental health services and supports. So if we are right now in wave 2 and 3, wave 4, as identified by Dr. Seng, includes psychic trauma, mental illness, PTSD, economic injury, and burnout. So the focus increasingly goes from public health to health and social to mental health issues. So in my mind, given that there is a bit of a lagged and perhaps even a pent-up demand for access to mental health services, the focus around the supply side of the equation becomes really important in a way that in many instances, when we talk about our healthcare system and its overall structure and design, we focus, I would say, a little more, if not disproportionately, on the demand side of the equation. So I also think in terms of what the study is capturing well is the interplay, if not comorbidity, between mental health and substance use. In many respects, they are inseparable for many Canadians who have both at the same time or have had one that leads to the other. There are clearly instances where mental health and substance use exist in isolation, but it is nice to see the balance between the two. I think also, and Rebecca touched on this point in quite some detail, is the issue of equity And I think that is knowing that there is a differential impact on diverse and marginalized communities and populations is very important in terms of how we respond. I also think because this is an area that has, I would imagine, more gray literature than robust published literature in this area, this is quite important in terms of what we're trying to do in terms of building on that and putting it into a more rigorous, systematic assessment. And it also touches on, just in terms of from a policy perspective, and Rebecca noted this, the data is weak when it comes to assessing the size and magnitude and current potential of the mental health and substance use workforce. And this may be a call to action for CHI in terms of its data abilities and developing more robust data capture elements in this area. But that is a challenge that I'm hoping that this study will continue to highlight. And that leads into my final point about what I think we're doing well in terms of this study is, at the end of the day, this is about policy responses. So while we may provide a diagnostic around the size and dimensions of the issues, policymakers and other audiences out there will be looking for solutions. What are practical solutions in terms of moving forward? In terms of gaps, I know the two objectives of the study focus very much on the context of COVID, but one of the challenges would be knowing that, and I don't mean to be trite here, but pandemics do come and go, and it may be a while before this pandemic does go. But what are the lasting policy instruments and impacts that we also need to think about in the context of a lasting series of investments that ensure a sustainable workforce, not only in the sense of a growing demand in the context of a pandemic bubble, but as we move forward and get to the new normal, what does that mean in terms of overall system architecture and design? In many respects, mental health and substance use, they are the orphans, the orphan child or the orphan children of Medicare. So I think we need to think not only now in the context of what is currently before us in COVID, we need to think more medium and long-term strategically about this whole sector and making sure that we have the appropriate workforce needs to meet demand. One of the other challenges, I think, or it may even be a gap, but I think it's something that will be dealt with, is the whole issue of the mental health and substance use workforce. They are very much a heterogeneous lot, even though we may use a title that kind of homogenizes the sector. There are many, many different providers that make important and valued contributions. Some of them are not even paid, certainly when you think of peer support, but they have different roles, responsibilities, and scopes of practice. So as we think about the workforce, just with one word, there are many different dimensions underneath and many different moving pieces that need to be considered in the context of solutions and how we move forward. Part of the other challenge as well, and Rebecca again spoke to this point, is that one size doesn't fit all in terms of solutions dealing with mental health or mental illness, mental health disorders, along with substance use disorders. So there needs to be flexibility in the context as to how we look at what the current pandemic situation is telling us, what the international literature and responses are telling us, and then how we bring it down to the local level. In many respects, notwithstanding national trends and international trends, all innovation is local. And I think we need to think practically, and policymakers certainly, whether it's at the provincial, regional, or municipal level, will be looking bottom up as to taking some of the information, the key findings that we have with regard to the study, and figuring out how we bring it down to the ground and apply it in a very practical way. In terms of the last question, I think data certainly was a real important piece for me in terms of, again, it's difficult to monitor and measure what you're doing without good data. So how do we move through where we are? And we have certain data building blocks upon which to build, but clearly there's some major gaps that need to be filled. And then the other piece, just coming back to it, is as much as we focus on the urgent, we can't let it crowd out the longer term importance in terms of looking at system response and making sure that we have capacity that not only deals with obviously an unprecedented situation like COVID, but also as we move out of it and moving forward. So I'll stop there. Thank you for the invitation, Mary.
Thank you very much, Glenn. And you know, if you're calling this unprecedented, that's I think a good thing. So lots of challenges, but lots of opportunities too. So I'll turn it back to Ivy to moderate the Q&A.
Sorry, my apologies for not being unmuted yet. I just wanted to, I had handy the graphic from Victor saying that, that Glenn referred to. And so it very much speaks to the discussion around we can't just focus on the urgent, which is this pink or purple, depending on your screen. And we really do need to sort of focus on what's happening in the background. So yeah, I just wanted to share that in case people didn't know what graphic Glenn was referring to. This is the one. So with that, so some people have been introducing themselves in the chat. I encourage you to continue to do so. We haven't had many posted questions or anything like that, so I'm really happy to just kind of open it up if you would like to unmute yourself and pose a question. That can be to Jelena, who has really got sort of the handle on the published literature. Danielle, who's really been focusing on the gray or stakeholder literature. Kate is one of our team members who's really focusing on sort of the background legislative context. And Mary and I sort of are leading on the project, and would also like to make sure that we acknowledge Carolyn Chamberlain-Rowe, who will be involved in one of the other aspects on the project in terms of aligning population health needs as those are growing through the pandemic, and how do we get at the responsiveness. And I did mention that we are working diligently on a survey. And so if you have any ideas about members of the mental health and substance use workforce that we should capture in the survey, so who we should be asking questions of. And we really do take that big tent approach that, you know, that Glenn raised and that Rebecca raised, in terms of we're talking sort of the whole of the health workforce here. And so if you can add some comments and specifically if you could identify certain workforces that we should capture, as well as who we might want to partner, you know, in terms of getting those surveys out. The comments about, you know, this being an orphan of Medicare, it's very much an orphan of any form of data. And we have this very small, short study that has a huge remit. And so we just really, really need your help to provide us with some guidance and some linkages. So really happy to do that. So please do unmute if you have any questions that you would like to ask.
Hi, I do. I think I just have comments. As I introduce myself, my name is Anke Lenske-Johnson. I sit up in northern Ontario, Elliott Lake. You must have heard about this place where the roofs fall down. Not funny, I know. However, having said that, I just wanted to talk about the gap, and probably you know the gap, but I need to voice it sitting where we are. We are dealing with a very small city. It's a city, but there's only 13,000 people there, or that's counting cats and dogs, I believe. In any event, for us, it's a big issue that we have people coming from surrounding areas who don't have access to any service we could and I'm saying could provide, clearly virtual. That means through media, as we are right now meeting here as well. So my small little program, which is a psychosocial rehab program for adults with mental illness, we have 2 workers there, and they did during lockdown and still are. The numbers are changing again. We are from face-to-face to more telephone supports again. So absolutely, you have identified it. Training is a gap for us to pen with that. However, what I find is I'm the administrator, the AD, that my staff is burning out because it's a very different service delivery to doing sitting on the phone for 8 hours or 7 hours per day and supporting people. Furthermore, there's challenges that we have people who don't even have a phone. So very demoralizing for staff as well. Usually those are people with very high needs we can't even reach. Secondly, I talked about the burnout of staff. Secondly, the issue around any resources we could offer them through a cell phone or through a computer. People don't have the equipment. And secondly, we don't have the reach of the data. We don't have the reach. We have people in areas there is no internet connection, no Wi-Fi, not Wi-Fi, but cell phone connection. So we can't reach those folks. And in terms of our seniors mental health program, it is an issue too. Of course, when the infection rate is high, we can't go into the facilities as well. And I'm again demoralizing staff. I hear from my nurse how sad it is that relatives can't. I mean, you're very aware of that situation, that people are lonely and digressing even further or quicker than they would usually with some personal contact. So yeah, I think from my perspective, we are very busy with policies and all this good and PPE and all this jazz and trying to implementing, and I didn't mean that disrespectful with jazz. We are trying to implement all the good things to keep everybody safe and are busy with that, but I wish I could tell my staff, go home for a month and go somewhere where you can recoup and recharge. That really is an issue. And we do lots of self-care stuff. I provide them with information and yada, yada, but whew, it's really very exhausting. Capacity is, and it's not by lack of, we have new people coming in wanting services. So that's my rant. Thanks.
That's a really, really important set of comments, and for us to take into consideration. We're very, very sensitive to issues in regards to accessibility. And I think that there's very much sort of a sense that, you know, because we are all connected, that everybody else is connected, and we don't take those things into consideration. So really very, very much on the population side, what do you do? How can you provide support remotely? So yeah, really, really important. Mary, did you have any comments that you wanted to make?
No, I just really appreciate Anka sharing, and I think those examples of the way in which burnout is affecting the workforce, especially as we grind along through the pandemic, is something that I think is to some extent an emerging issue, especially it's true for the population as a whole, but it's also true for the frontline providers in a really real way. And it's not just, I mean, yes, it's people who are providing direct pandemic, you know, care for COVID patients, and there's been a lot of focus on the mental health needs of frontline healthcare providers, which is really important. But we also need to think about people who are providing frontline mental health and substance use services, and what kind of supports as well for people who are working with some of the hardest to reach folks that you mentioned who may not have, say, like cell phones, or I was talking earlier with people working with homelessness organizations and the demands on their workforce. Rebecca spoke about some of the harm reduction workforce and the double whammy for people who are working to try to prevent opioid overdose at the same time as dealing with the PPE and the public health measures. And meanwhile, we go home to our own lives, if where we are also dealing with the impacts of the pandemic. So I think there's a lot to consider in what you spoke about. So thank you for sharing that. And we'll certainly be including those kinds of experiences in the work, in particular in the qualitative key informant interviews that we do, to really understand what people are experiencing as part of this project.
Yeah, it's very much a mixed method study. So, we are using the surveys and the scans that we are doing to build a survey. And that's why I said, if you could provide us any advice about that, but then we will be following up to better understand through these stories, because there's only so much that you can capture and measure quantitatively, and we want to capture the complexity. I was thinking about that visual. Some people may have seen it. It's been going around, Facebook and Twitter and other social media, of the health worker who's underwater holding up the hospital bed. And I want to also think about all of the mental health and substance use workers who are holding everybody else up around that hospital bed. And so I think that there's another graphic that we should be looking at. Megan has added something into the chat. So thanks so much, Megan. And I think it's a question that I can direct to Yelena. So she says, thank you, Anka. We have primary care nurses or community health nurses that also provide mental health and substance use support for all ages in their practice. I'm wondering if the literature has reached out to these generalists as they provide mental health and substance use care and services. And just as I go to Yelena, this is a group we definitely want to capture, the generalists, to understand how much they have pivoted. Family physicians, pediatricians, geriatricians, just various physicians, as well as nursing workforces that may not have a focus specifically on mental health, occupational therapists as well. So looking at that sort of generalist population. So Yelena, how much has come up in the published literature? And maybe Danielle, you could speak to also what you found in the national and international scans.
So there are not so much on this issue in academic literature. There are a few articles talking about this. When they talk about rural care, it's usually referring to challenges for clients, how it's harder for them to access the care, but it doesn't talk as much about challenges experienced by providers, which I find quite interesting.
I can just add on the gray literature, and a lot of the places we've been looking have been more at generalist practitioners. So there won't be those specifics necessarily about here's what we did for mental health, for patients with mental health or substance use concerns, but it'll be here's how our nurses started giving virtual care. So we're sort of scratching the surface on what you're saying, definitely including all the generalist practitioners, but sometimes it's not so specific which part or how much of their capacity they're using for mental health care versus more medical care. So I hope that helps a bit to answer your question.
Yeah, thank you, Danielle. And also just to kind of let people know, I mean, some of this work was building on some commissioned work that we did for the Canadian Foundation for Healthcare Improvement. So we did an overall scan looking at different health workforce strategies in response to the pandemic. And we were very interested, and where I had the graphic was in the very first webinar that we did where the team presented that. And so there was a lot in terms of workforce strategies on the mental health of the workforce, not explicitly directed at the mental health of the mental health workforce, the mental health and substance use workforce. But in fact, that workforce was providing support for the broader workforce. So, you know, some work through CPA. And so some of those things are captured in the online database that we have, and of which we are still adding to and contributing to. And so yeah, if there are any, you know, innovative approaches, and I see Julie has added to the chat an example of a sort of a task force who have identified issues around workforce continuity as being really important. And especially, you know, we talk about continuity of care in the maternity care workforce around midwifery, but continuity of care is so critically important, you know, not having to kind of retell your story, you know, of how you're navigating things, you know, from a mental health and substance use perspective. So that's important to mention as well. So do have a look at, you know, some of those other resources and provide us with some other examples. So I'm just going to open it up and see if anybody else would like to contribute. We will, just by way of housekeeping, we will stop the recording at 2 o'clock. And if others have to go on to their next meeting, you're welcome to do so. But we will stick around for some time afterwards if people would like to have an open discussion, not being recorded. So welcome any additional comments. All right, I think I've given our requisite, you know, certain number of seconds to wait for that. And so I would like to thank everybody, all of our speakers, Rebecca and Glenn. Glenn, thanks so much for pinch hitting right at the end. That's really wonderful. Thanks so much for doing that. And also just want to acknowledge that we do have members of our advisory board on the line. So to thank them for attending, and we will be gathering again with them. So please feel free to send us information. Mary has left up our contact information. And as you sign off, if you want to leave any additional comments in the chat, we would very much welcome that. So thank you again to all the presenters, advisors, and participants.